Perhaps I can start. I think Philippa mentioned, I think everyone mentioned that clearly we've got successful treatments and a potentially successful strategy. And it's all about access. And there are questions saying, how do we actually get more access and remove the barriers? So perhaps we can start with you, Rania, and your experience of how we may be able to remove these barriers to allow greater access and therefore greater success.
Yeah, sure. Thank you for the invitation to be on the panel. So in terms of access to vaccination, I think that, as we've seen in all the presentations, the African region is one that's really lagging behind all the other regions in terms of the introduction of the birth dose. Based on experience in the Western Pacific region, which originally had one of the highest prevalence, in children, and now the incidence is less than 1% in children. The biggest kind of push for getting birth dose introduced is government support and political commitment. So first, you really need the country, the ministries of health, the ministries of finance to see the importance of the introduction of a birth dose to make it happen. And all the evidence and the data that the studies are showing, it's clear that the Hep B burden in most of the Afro region countries is quite high. It's over 8%, especially in the woman getting pregnant now. So there's a higher risk of mother-child transmission. So that's the first thing, getting the political support and the commitment to get it introduced. The second kind of barriers, I think some of the people alluded that in their presentations, is the high rate of home birth in many of the countries. However, based also on experience in other regions, there are interventions which can be done to get the vaccine for children who are born at home if there is commitment and there is, awareness and advocacy and demand also from the population. So if a country, I think, decides to introduce a birth dose, one of the biggest kind of access issues is starting with hospital birth. It's very easy when you have a vaccine in a hospital setting, and there are usually cold chain in the hospitals available. And even if there are no cold chains, as we know, the hepatitis B monovalent vaccine is very heat stable. It can be kept outside the cold chain for some time. And there are several studies which have shown still the efficacy and the effectiveness of the vaccine when it's kept outside the cold chain. But we need more studies in the African context to show that it is still impactful in that setting as well. So all of the studies are in the Asian context. So we need more data from the African context to show that this is a safe way to give the vaccine whenever we don't have cold chain. So starting with the hospital birth, we need to create awareness among the healthcare workers. So as Maud mentioned, there's a lot of awareness that needs to be created both among the healthcare workers as well among the population, the pregnant women, educating them during antenatal care that, as soon as the baby is born, they need to ask for the birth dose to be given to their child to prevent liver cancer. That's the vaccine that was first created to prevent a cancer since the 80s. And we still see this challenge in getting it introduced in the African region. And also a lot of the evidence from the Western Pacific region showed that, when you commit somebody to give the birth dose. So it says whoever delivers a baby gives a birth dose. You don't need to wait for, a certain person who would need to come to give the birth dose. So this would allow, even if a baby is born on a weekend, the birth dose is given. So there are certain kind of policies and guidelines that might need to be revised to make access more available and improve coverage. And as for the home birth, which yes, is more challenging to reach them, but it's not impossible. There are ways to do that. There are ways to link community health workers with health facilities. Whenever a child is born, even if it's not within 24 hours, even within 3 days, is still effective in preventing mother-child transmission. Yes, it's not as effective as within 24 hours, but it's better than nothing. So linking them to community health workers. And here we see that there's a strong need for collaboration among programs. in terms of, for birth dose vaccination access. There's a strong need for, collaboration between the immunization program as well as the maternal and child health program, both during the antenatal care period and the postnatal care when, there's postnatal care visits being done at home. Why can't we integrate birth dose vaccination as part of this, of this visit as well? So there are various interventions that can be done, but I think most of our evidence is coming from the Asian countries. So we need more kind of similar interventions implemented in African countries to get this data out and to show the countries that this is not impossible. It can be done if there is commitment. But the first thing is you really want the country to support that from the higher levels to make it happen.
Thank you. That's really great. Philippa, can I ask you then briefly, if you could just say, politically what you think can be done, perhaps from a WHO level?
Well, I think there's the two interventions. There's the vaccination, and then there's the antiviral prophylaxis. And I think we have seen time and time again the importance of political leadership and engagement. I think on the vaccination side, there's no doubt that the engagement with Gavi, the Vaccine Alliance, and with the Global Fund to facilitate funding. And so I think that was an important step forward that really, when it was, there was a commitment from Gavi, initially planned for 2020, which will be deferred now probably until 2022 because of COVID, to really help support the sort of some of the kind of operationalization of implementing birth dose in the 50 countries that do not currently have this. The opportunities for funding from the Global Fund through the integration with supporting and strengthening maternal and health services. So it's very important that countries take
Oh. So we seem to have lost Philippa there. So I don't know whether to interrupt or if she's suddenly going to come back. But Maud, perhaps I can just ask you, there's quite a few questions, but no one has mentioned anything about TAF. And you actually said something which struck me about tenofovir and saying that there was no real data in African women. So are you saying we ought to edge forward with caution in using it in African pregnant women? And can you just say something about, do you think TAF will be safer or less safe?
Thank you, Mark, for your question. The data we have on tenofovir are only coming from the field of HIV, so HIV, HPV or non-HPV pregnant women. The data we have, so we have no data on TAF in Africa in pregnant women, but I don't think it's particularly needed because we have now accumulation of data showing that tenofovir is extremely safe during the pregnancy for the mothers, but also for the babies. We have even long-term data now about infants who have been exposed to tenofovir. These data are coming from Asia. And regarding the kidney toxicity, this is something which is mainly observed in HIV co-infected patients. In mono-infected, it is not a problem. So I even believe that we could easily give tenofovir to this pregnant woman and even probably not to have to monitor the kidney function to simplify the management of this patient.
Okay, and can you say something about why we use, there's a question about why are we using monotherapy and not dual therapy, particularly late in pregnancy?
No, it's a very good question. It's not needed. The biggest difference between HIV and HPV, you don't need to achieve a full suppression of the virus at delivery. We are very happy, even if the mothers still replicate a little bit. The most important thing is to have achieved a decrease in the viral load, because we know that below, we are not so sure about the cutoff in Africa because we don't have enough data from Africa. But if you look at the Asian data, women who have a viral load below 200,000 international unit per liter, they don't transmit the virus. So the most important thing is to have a decline. So immunotherapy is enough.
And briefly again, is there a role for cesarean section at all?
No.
Okay. Philippa, sorry, we lost you a little while, so hopefully we won't again, but there were 2 or 3 people asking about your cutoff for therapy at 200,000 and whether that was too high.
Well, this was based on the systematic review, and I showed the slide from Yasuki of the 66 studies, and showing that really below that threshold in the context of birth dose, there's very, very little transmission. And so there did seem to be a clear threshold effect. And this is in accordance with the ASLD and EASL and other guidelines that, and the Chinese guidelines that have used this threshold. I think it's fair to say, and I think when I managed to reconnect, I think Maud was, well, I think several of the panelists have commented on the lack of data for Africa. So I do feel there is a need that for us to re-look at this question in the context of sub-Saharan Africa, because almost all the studies were from Asia.
Okay. So Manal, I hope these questions are in your field, but if not, we can ask someone else. But someone, I know during the Gilead symposium, there was a question on breastfeeding, and the statement was it's safe, but people would like clarification on that. You know, is it safe for everyone? What about very high viral load patients? What about people who may have cracked nipples, bleeding from the nipples, etc.? Is it 100% safe to breastfeed? And the second question was, does Delta affect transmission or the success of vaccination? Those are the questions. Manal, would you be happy with those? Clearly not.
Mark, I can respond regarding.
Yeah, okay, Maud, please do.
Just to help, it's a very important question, but the good news is tenofovir has a very low biodisponibility, and there are several studies showing that the mother who are exposed to tenofovir have very low level of tenofovir in the milk, and children are not really exposed. And the most important thing is if the baby has been fully vaccinated, there is no problem to breastfeed, and they should be breastfed.
What about Delta? Can you answer that one? Does Delta?
Regarding the transmission of HPV,
well, not that, but how does it affect the success of, yeah, well, yes.
If they are fully vaccinated, I suspect that we don't have many data about that, but infant vaccinated are definitely protected from hepatitis Delta infection. And importantly, mothers who are co-infected with Delta have a very low replication of B. So the risk of transmission of hepatitis B.
Manal, you're back. We lost you.
Yes, I'm back.
But Maud has answered your questions for you, so you can continue to rest.
Right.
Yep.
Okay.
So can we have the last question I give to you, Rania, because one of the things that came up again was mistrust in health services. And I suppose that's a much bigger question than just hepatitis, but how do we improve that in the African setting, do you think?
Well, that's a big question. I think it needs
and we've
more.
got very little time, so.
Yeah. I think it's more, you know, I would say somebody from the local context would have a better idea how to build more trust in the healthcare system in each country, because I would assume like the mistrust would be different depending on the countries and what happened in the countries. But again, it's kind of showing, you know, from the, you know, hospitals or the health centers, kind of investing in kind of making improvements in these services. And we've seen data, for example, in India. I mean, that's not in the African context, but they were encouraging women to come and deliver in the hospitals, but yet they were not improving the obstetric care or the delivery of you know, the delivery services in these hospitals. So women were not coming to the hospitals, even though they're encouraging them, or they were not having positive outcomes. So if we want to encourage women to a health center to come and deliver, we want to make sure the services that they provide are good. And that's how to kind of build more trust.
Now, do you want to say anything on that?
I think we need to work as well on with the stakeholders on the ground, particularly the civil society and the NGOs. There are lots of very, very strong patient support groups and civil society and even women. There is one group from Nigeria, for example. They're training women and improving their knowledge and awareness and increase demand and empowerment. So I think this is something that might be key to improvement of the health services and the implementation as well of the vaccination and the screening of pregnant women.
Great. So I really think we need to, we're a bit over time, so we should stop there. I'd like to thank you all, particularly Philippa, who's given her talk at a very short notice, and it was excellent. So thank you particularly, but thank you everyone for joining in and hopefully making the whole conference a success. So thank you very much.
Thank you.
Thank you.
Thank you.